Good evening, respected teachers, doctors, students, and homeopathy enthusiasts from around the world. Welcome to the 2122nd day of the uninterrupted daily webinar series of the International Forum for Promoting Homeopathy. I'm Idea. I'm a third-year student from Adilashramam NSS Homeopathy Homeo College, Kottayam, Kerala. So today's topic focuses on a condition that has become increasingly common among women of reproductive age, polycystic ovarian syndrome, traditionally known as PCOS. While conventional understanding once viewed it largely as a disorder of the ovaries, homeopathy has long recognized such conditions as expressions of a deeper constitutional imbalance affecting the whole system. In homeopathic practice, PCOS, now PMOS, has never been seen merely as an ovarian problem. It is understood as a holistic disorder involving the whole endocrine system, metabolism, insulin regulation, emotional well-being, lifestyle factors, and overall vitality of the individual. Because of this wider understanding, the term PMOS or polyendocrine metabolic ovarian syndrome has been proposed by many researchers to better reflect the complex and systemic nature of the condition. The shift from PCOS to PMOS emphasizes that the syndrome affects not only the ovaries but also various hormonal and metabolic pathways throughout the body. To enlighten us on this important subject, we are privileged to have with us Dr. DIVYA JALU MD, Assistant Professor in the Department of Obstetrics and Gynecology, Rajkot Homeopathic Medical College, Parul University. On behalf of IFPH, I extend a warm welcome to our esteemed guests and all the participants joining us today. We look forward to an informative and thought-provoking session on PMOS, a polyendocrine metabolic ovarian syndrome, current challenges, and future direction. Welcome, ma'am. The platform is all yours.
Nicely warm welcome by Arya. Thank you very much. Now I share my screen with you all.
Yes. Yes, ma'am. It's visible.
Okay. Am I audible?
Yes, ma'am.
Okay. Thank you. Myself, Dr. Divya Jalu, an assistant professor in the Department of Obstetrics and Gynecology in the Rajkot Homeopathic Medical College, Parul University, Rajkot, Gujarat. So, thank you IFPH portal for arranging such a webinar for enlightening us through various webinars and various topics. It is my great privilege to perform here. So today's my topic is PMOS, a polyendocrine metabolic ovarian syndrome. Current challenges and future directions. So why I choose this topic? Because now as we shift in medicine, any new format or new directions we get from a new rediscovery. So before, it is known as PCOS, polycystic ovarian syndrome. But the misnomer or the PCOS term is leading to underdiagnosis or overdiagnosis of the conditions. But it never holistically understand a person with this syndrome, or it leads to confusion in diagnosis and treatment protocol. So this new term PMOS is greatly helpful to understand the holistic perspective of this syndrome. So, what is the scientific evaluation of the PMOS? So, why we need to change this term? To understand that, we need to analyze what is the global burden of this disease. So, nearly 170 million women are impacted by these conditions worldwide, or 8 in 1 woman of reproductive age group are suffering by these conditions around us, and nearly 70% of the female are remain underdiagnosed. So, 70% of the cases remain underdiagnosed, so they don't avail any treatment or any management protocol. So, we are failed to give proper management and proper holistic health care because of this underdiagnosed S. So, what is the old and new view of this syndrome? The evolution from an isolated gynecological disorder to a systemic disease. The old view given by Stan Leventhal doctors that identify as Stan-Leventhal syndrome, that is PCOS, polycystic ovaries ovarian syndrome, where there is amenorrhea, infertility, and enlarged polycystic ovaries are there. We count it as a PCOS. But the today's view has changed. The today's new view is polyendocrine metabolic ovarian syndrome, in which we incorporate all the underlying disease conditions, whether it is from an endocrinal view, metabolic view, or genetic predisposition, neuroendocrine regulations, gut microbiome changes, and personal or psychological issues. PMOS denotes every aspect of this syndrome, while the PCOS is limited to an organ, that is ovary. So, why it is so? So, the PCOS is the name which implies a pathological limitation at the one organ. When we see polycystic, it means ovary has a cystic multiple cyst in it. So the name does not answers our question. The why syndrome is there. If the one organ is affected, and why we denote it as a syndrome or multi-system affection. So the cysts we are looking in the ovaries are not pathological cysts. These cysts are antral follicles which are arrested in development. So this is a normal cyst or follicles that are arrested in development, in mid development. So there is no any pathological conditions in the ovary, but an dysfunction or folliculogenesis disruption in the ovary. The total pathology or pathophysiology is idiopathic for this condition, as we all know. But the predisposition, but some are the factors affecting PCOS or PMOS is insulin resistance, metabolic changes, and psychological stresses or depression related issues. These all are working in a loop, but we did not know what it started or which one is started the PCOS. So when we say the polycystic ovaries, we limit ourselves to a organ, and many a times the symptoms of the multisystem is ignored. So we cannot provide holistic care to the patient if we only looking into the polycystic ovaries. We had to broaden our view to see multiple system affection. PCOS or PMOS is not a localized defect. It is a systemic crisis. From pituitary glands, we see FSH-LH imbalance, which lead to excessive androgen production from the ovaries. Along with, we see pancreas increasing insulin, or we see hyperinsulinemia state. Then we see the reduced sexual hormone binding globules, which renders the free androgens into blood, which this free androgens stimulates the ovary and arrested defolliculogenesis. But we do not know where it started, but this loop is recurrently going on. Now, why we need to understand this condition? When we repeatedly see that patients are underdiagnosed and are not getting proper holistic care, many patients and researchers, doctors, and various societies are identifying that this norm PCOS is a misnomer. It not include all the aspect of the PMOS or all the aspect of the PCOS. So we need to change our view or perspective. So how we can do that? The many patient and Professor Helena Teed from the director of the Monash University, along with the endocrinal uh, Monash Endocrinal Center, Research Center and Implementation Center had led this name change process alongside the International Androgen Access PCOS Society. So how they do it? They did by the Delphi surveys. They step by step they do research, asking patient organizations, various societies, and getting responses from workshops, patient organizations, various hospitals, and various research clinics. They collect a huge data on which they identify that the PCOS term is lead to many disturbances, or it will not lead us to give proper care or holistic care. So we need to change a name where we can directly identify from the name that now this is what we are looking at. The PMOS is identifies as poly-endocrine. The multiple endocrinal hormonal disruption is there. Metabolic. We have metabolic disturbances. Ovarian syndrome. So ovarian or reproductive disruption is there. So the PMOS is includes all of the symptomatology in the name itself. The why the PMOS name is accurate because it includes all the aspect of the PCOS underlying pathology, and it is a culturally informed. Why it is culturally informed? When we look from the view of PCOS, where our focus is on polycystic ovary. So when a patient is diagnosed with the polycystic ovary, the stigma is that that patient is unable to conceive, and that is not entirely true. So the patient lives in a depression or anxiety state. That patient lives with stigma that if she has PCOS, she is infertile. But that is not true entirely. So the PMOS is the culturally informed. So when there is polyendocrine metabolic ovarian syndrome, it means that patient has not symptoms limited in her ovaries, but also connects the all the systems, and they can treat according to. The PMOS is the more than just a label. What is the systemic impact of the PMOS? Let's see. Accurate nomenclature. The removing the cyst misnomer is leading with hormonal and metabolic realities. In PMOS, we could include all the conditions underlying the syndrome. Accelerated recognition. What is accelerated recognition? That 70% of the underdiagnosed test, we can readily identify that if these kind of symptoms are in the patient, then we need to identify or look for the whole PCOS symptomatology. So we can avoid the underdiagnosed cases. This PMOS lead to multidisciplinary care. When we shift our view from isolated affected organs, it leads to a broader view. So when first the PCOS care is limited to a gynecological hospital or fertility clinic, but now we can incorporate multidisciplinary like endocrinology, cardiology, and metabolic health alongside. So we can say that we upon multidisciplinary care, we can have holistic healthcare for long-term cures and optimizing lifespan. Why is it so? That if we are diagnosis PCOS early on and treat accordingly, treat perfectly, then we can avoid the risk of psychological distress, cardiovascular disease, that is atherosclerosis, and endometrial hyperplasia and endometrial carcinoma due to chronic anovulation or excess exposure to estrogen. So we can avoid that into later on. So the early diagnosis and early treatment is necessary. But when we are not identifying the underlying cause or when we are not identifying the syndrome, it will not help us for a long-term care. So how will be the name change process will be changed or how will get it to global implementation. The same researcher has provide the blueprint for it. That is the phase 1 to 8. The phase 1 is academic dissemination, a publication of the consensus, clinical review, and immediate update to the medical textbook. The second phase is resource development, that is co-designing multilingual patient and clinic resources across the platform, that is physical and virtual. The phase 3, global engagement, launching society toolkit, multimedia campaign, and professional education programs worldwide. And the healthcare integration, that is embedded records into the electronic records for the same. The phase 5 is policy and research. This name will help to understand broader aspect and create new policies for it. The engaging governments, pharmaceutical companies, and research funders to align classification and funding of the disease. The phase 6 is global classification. The formal engagement with the WHO for integration into international classification of disease. The phase 7, the managed transition. A strict 3-year monitored transition period evaluating evidences on emerging subtypes. And the phase 8 is the 2028 mandate, the full integration into the international guidance and deployed among the 195 countries. So through these phases, we can implement the misnomer, we abort the misnomer PCOS and transfer it to a PMOS. So PMOS will lead to various changes. So one slide is remaining. Let me show you what is the pros and cons of the name change. So when we look into PCOS, the pathologically we see the localized structural defect. But in PMOS view, it is polygenic, multisystemic disorders and multi-organ is affected. The primary clinical focus or primary treatment focus is fragmented in case of PCOS. Why so? Because we see PCOS as a polycystic ovary first and treat according to that. But it is not entirely correct because underlying endocrinal disruption, metabolic disruption are ignored completely. So the care of the PCOS is fragmented or scattered among the gynecological and fertility clinic. And in PCOM, we can say that multidisciplinary care lead to holistic care, including endocrine, metabolic, and reproductive disruption. So we can get that from that. The patient impact of PCOS is a high stigma regarding the polycystic ovary directly related to infertility. So there is high stigma and delayed diagnosis that we see how delayed diagnosis is done in later on, or confusion And the PMOS is provide scientific clarity that it includes all the affections in the name itself, or this short abbreviation, that is polyendocrine metabolic ovarian syndrome. By the name, we get the view or gist that this will be affected or this is affected here. And the name is itself is validating the underlying pathology and culturally appropriate, yet it not imply any high stigma and epidemiological utility. The PCOS is obscures the metabolic disease risk in the body, and PMOS is aligns coding with lifelong cardiovascular and metabolic risk. So the PMOS is necessary change. Okay? Not PCOS is not, we can say, the entirely incorrect, but it limit our us to a specific organ, and we treat that only. But it is not going to help us for long-term health. So when we say PMOS, we holistically cover the entire disease conditions, underlying disease conditions. So it is a necessary change to abort a misnomer PCOS and introduce new PMOS. So what is this? This change was driven with and for those affected. This is start with the patient asking why my PCOS is not correcting even after this treatment, because we are not correcting all the things at the same time. We provided fragmented care for individual symptoms. So a researcher and various societies came together and changed the name or start the change name process. It is a landmark moment that shifted the conversation from a misunderstood symptom to a holistic demand for equitable lifelong health care. By aborting the misnomer cyst that directly says that a organ, individually organ is affected, that is ovary. This name leads us to a holistic understanding of the disorder. So we can now provide and understand patient as a whole, which we are doing in homeopathy for 2 centuries. We know that patient, we cure the patient and not the disease. And this is what they change now. They say the multiple system is affected and nobody knows why it is multiple system is affected. But as a homeopath, we know if we get a proper case taking and identify the patient's history, or family history, or personal history, or everything, we get to know that why this disruption is occur in this patient, and we treat according to. That's why our system is holistic and practicing more over than 2 centuries. But the modern science has understand that now, and they are changing or reframing their treatment and solutions. So let us understand the PMOs with again new perspective. To understand PMOS, we need to understand the four main pillars of the underlying pathophysiology. As we all know, the first is genetic susceptibility, hereditary pattern affecting insulin signaling, ovarian steroidogenesis, and gonadotropin regulation. If a patient's mother or sister have PCOS, have history of PCOS, this patient can have PCOS or PMOS. So the hereditary susceptibility is true. The next is insulin resistance. The pancreas overproduces the insulins that stimulates the theca cell of ovary, which produces androgens. These androgens lead to hyperandrogenism, excess insulin leads to androgen spikes. That androgen spikes lead to follicular disruption in the ovaries, and also free androgens due to decreased sexual hormone binding globules from the liver. We have free androgen, which is account for hirsutism, androgenic alopecia, and androgenic acne. So it also leads to dermatological concerns. And the hyperandrogenism state, it also changes the gut microbiome of the patient. So what it does dysbiosis of the normal gut bacteria and lead to leaky bowel. What is leaky bowel? When this bacterial changes is going on, the toxins from the intestines renders outside the intestines or past the intestinal lumen and goes in extracellular space and blood. These toxins are the culprit for the chronic low-grade inflammation. And this inflammation is usually worsening the insulin resistance. So, once this loop is started, the recurrence is almost, we see that recurrence is high and this loop is ongoing. We need to address everything at one time to correct the patient, to correct the symptomatology. If we only affect that say that insulin resistance is treated by metformin, but it will not help if there is polycystic ovary or if there is low grade chronic inflammation. We need to address everything at one time. Why it is difficult to treat a patient with PCOS or PMOS? As a homeopath, we can understand it very effectively. Why? There is clinical heterogeneity. As we say, no two patients are alike, or no two patients are identical. So in homeopathy, we say we not treat disease, we treat patient. This small sentence, modern medicine has understand now that we need to understand patient individually. But a homeopath is doing more than over 2000 years. So let's take for example, what is clinical heterogeneity? And the patient A has reproductive issues like oligomenorrhea and infertility. Along with that, they have psychological issues like anxiety and depressions. Or the other symptoms of PCOS syndrome is not there. Only two symptoms or two system is affected here. And the second patient B has hyperandrogenic state, that is hirsutism, acne, and alopecia, and have metabolic changes, obesity, and insulin resistance. So we cannot give these two patients a standardized one common treatment. We need to have different treatment for both the patient. So this standardized treatment fail to address a specific phenotype, that is specific constitutional affected person of the individual. It is not treated by the standardized treatment. That is the what modern medicine has always emphasized, that on the disease condition. They say if this disease is there, we need to prescribe this medicines or this medical regime. So they have one size fit all process or concept, but this is now not working. So we need to address a patient holistic or individual care. The diagnosis of this case, the why it is difficult or why it is more confusing, or why we have 70% of the female underdiagnosis of this syndrome. When we have PCOS, we diagnose it from biological markers and USG reports. But along with that, we have special Rotterdam's criteria for diagnosis of PCOS, which includes ovulatory dysfunction, clinical and biochemical hyperandrogenism, and polycystic ovarian morphology. To diagnose patient with PCOS, we need any two of these. The next is adolescent puberty. During adolescent pubertal ages, there is normal physiological fluctuation in the hormone and the irregular early cycles and physiological acne. Now, the Rotterdam criteria is saying an adolescent's puberty changes are alike or shared same physical or biological markers, which directly leading to a frequent overdiagnosis, underdiagnosis, and delayed treatment in young women, adolescent, and reproductive age of women. Because we see the normal physiological fluctuation, but the underlying, if we see in adolescent girl that for hirsutism or early regular cycle or physiological acne, if we account it for hydroandrogenism, hydroandrogenism, it is overdiagnosed. Or if we understand this hyperandrogenism state as a normal physiological changes, then we underdiagnosed it. So this confusion creates the danger, and this confusion lead to over and under diagnosis of this condition. This will directly imply or delay the treatment of the same. So this 70% of the patient did not get the treatment of PCOS. This will lead to chronic conditions in the later on. Now let's understand one by one. This temporary fertility problem is a lifelong systemic disaster. How? When during adolescence ages, we have diagnostic confusion, as we see before, and the onset of irregular cycles. So we have a lot of diagnostic confusion at that time. So we miss the diagnosis of the. So if we miss the diagnosis, we are unable to treat the patient or miss the treatment. During reproductive year, this will causes infertility, hyperandrogenism, and profound psychological distress. And why it is that happening is we see again. And up to mid-adulthood, there is metabolic syndrome, that is obesity, hypertension, dyslipidemia, and hyperglycemia. The risk up to 4 times higher from the normal public. If the female is with PCOS, she will have hypertension, obesity, dyslipidemia, or hyperglycemia state of 4 times higher risk from a normal woman. So this all bound to decrease the quality of life of the patient. And during late adulthood, this all lead to cardiovascular diseases and elevated risk of the endometrial carcinoma due to prolonged estrogen exposure due to chronic anovulation. When there is anovulation, there is constant estrogen elevation. There is no opposing progesterone. So this chronic elevated estrogen state will lead to endocrinal, sorry, endo, endometrial hyperplasia and then endometrial carcinoma. This state also increases the risk of breast cancer in a female. Now we understand the diagnosis and pathological symptoms of the syndrome. But what is the most neglected aspect of the PCOS is the mental symptoms, which we as homeopath implies more importance. But during a modern healthcare, the mental symptoms or the psychological symptoms are bound to be normal, that this conditions is there, so it is happen, it is normal, it will go off. That kind of sentences we often heard, but it cannot be neglected all at once. So why? The patient is living with it as distressing discomfort regarding these symptoms. For the first is depression. The depression is often often found from infertility. If the patient is unable to conceive and there is high social stigma, or it is culturally not appropriate from the view of socio-cultural aspect. So this will lead to depression, the anxiety disorders. The end patient is anxiety disorders and anticipation. Anxiety from appearing in the public place or into someone new or stranger. It leads to eating disorders. Eating disorders, especially bulimia nervosa, or when there is patient is gaining weight, overweight, either due to this psychological issue, patient is overeating, or due to weight gain, they starve themselves to reduce the weight. These both conditions adversely affect the patient. And the last is sexual dysfunctions. Due to changes in the hormones, there is changes in the desire for sexual intercourse or changes in the libido. So this help this affect the interpersonal relationship of the couple. So this all contributes to psychological issues of PCOS. It is just the symptoms, the physical symptoms, that is infertility, weight gain, cosmetic concern, and social stigma, but it profoundly affects the female with the syndrome. So we need to address it because it can worsen the conditions. Okay. Now let's understand the today's or the present management criteria for the PCOS or PMOS. What we have is standard pharmacological intervention to manage the symptom without curing the disease. When we say that modern treatment is fragmented or symptomatic, what we see, they apply a treatment, the symptoms are subside. Then they ceases this treatment and symptoms reoccur. The underlying cause is not identified and it is not addressed. So this recurrence loop is ongoing. So now we have standardized toolkit map. What we see, if we see menstrual irregulation, then we need to give patient oral contraceptive pills. Why combined? So when we give patient a only estrogen pills, it can worsen the conditions or worsens the lifelong risk of the cardiovascular disease and endometrial carcinoma and breast carcinoma. So the safe option is combined oral pills or estrogen progesterone pills. The insulin resistance is opt for metformin. And when there is hyperandrogenism, we opt for anti-androgen therapy. And when there is fertility issue or patient at desired fertility, we induce ovulation induction by letrozole. Letrozole is the first line medicine in the ovulation induction right now. So these 3-4 symptoms are addressed by various symptoms. So if the patient has irregular menstruation and desire for fertility, we cannot provide oral contraceptive pills and letrozole again combinedly. So what we can do? We don't know. We cannot do both at the same time. So we need a new innovative approach to connect or to address all the symptoms or all the aspect of PMOS along with everything. Symptomatology, psychological issues and menstruality. And when there is patient is desired fertility, we need to address it properly because the infertility patients have higher depression rates. So, why along with this treatment, they also provide healthy diet and weight management plan. But these two are cornerstone of the PCOS. The health management, that is healthy diet and weight management, is need to be done in a patient, that it will, even if the overweight PCOS patient reduce 2 kg of weight, the normal regular menstrual cycle bound to be regular, only 2 kg weight loss. So this will make perfect plan for treatment, or it will lead to increased curing part. Then these pharmacological limitations need highlight the need for the innovative approaches. Okay. So the innovative approaches, right now the emerging research is breaking the recurrence loop, is going, 3 main research for the PCOS patient is ongoing, and then what we see up to now, that is GLP receptor agonist, that is glucagon like protein 1 receptor agonist. For example, semaglutide and tirzepatide show promising effects on weight reduction, insulin sensitivity, and restoring ovulation function. The next one is gut microbiome. Alteration in gut bacteria actively influence metabolism, inflammation, hormonal regulation, and opening door for targeted therapy. When we identify the gut microbiome has changed or there is dysbiosis, we can target that particular part, and targeted treatment will lead to cure or holistic health. The next is artificial intelligence. Now, as we see AI is expanding, it also expanding in the medical field. So, how AI help here? The AI models are more advanced and feed all the required informations. So, these models are help in early diagnosis. So, the 70% of the underdiagnosis cases are now being diagnosed or early diagnosed by the AI models, and it can predict the risk prediction of the up- upcoming diseases. So when the during mid adulthood or late adulthood, patient has which type of the diseases or how we can prevent it, and AI can make highly personalized treatment plan for a specific patient according to the data or biochemical markers we feed to the model. So these are breakthrough in the treatment of PCOS. If we implement it correctly, or we get widely spread this condition, widely spread this access to this research or these drugs, we can effectively effectively provide long-term cure to the PCOS patient. Okay, this is about new research. But the emerging question is, if the conventional symptomatic treatment is not addressing long-term cure, what are they up to? So, up to now, we see that pathophysiology, diagnostic confusion, the name change process, everything. But now they changed the name because they need holistic care. Okay, holistic care means they need to include all the aspect, that is metabolic, endocrine, psychological, dermatological, metabolic, everything. So what is it? When we see that, they want to see it in a holistic perspective, but this isn't new. Why? We all know. So they know right now that the fragmented symptomatic treatment is not good for long-term cure, and it will not abort the long-term life risk diseases. In case of PCOS, that is cardiovascular disease, that is atherosclerosis, and endometrial carcinoma. The fragmented conventional symptomatic treatment will not address the risk or will not abort the risk of the this disease condition later in life. So what we need to do is we need to diagnose it early. Then we need to provide holistic health care along with the healthy diet and weight management. Only then we can properly cure the patient for it maximum or health, or we provide them maximum care. So this is what are they up to? This is precision medicine. What is precision medicine? They describe it as a patient-centric medicine. They describe it as right treatment at right patient to the right patient at the right time. Okay, it is patient-centric. Or precision medicines is driven from various genomics research and individuality of the patient. As we see clinical heterogeneity, this clinical heterogeneity is not accidental, but it is a property of an individual which make make susceptible patient to that condition or dispose to patient to that condition. That's why there is clinical heterogeneity even in same diseases. So the precision medicine is the future returning to an old principle. By precision medicines, if we understand, we get to know that it is a most accurate treatment. So the medicine is gradually moving from treating disease to treating individuals. Individualization, one considers as alternative concept, is now becoming a central theme of modern healthcare. Up to now, they are giving fragmented symptomatic treatment. But now they understand after repeatedly failing to cure the PCOS, they get to know that this will not help and this will not abort the long-term effects of PCOS. So they need to innovative aspects. Or by this change in the name of the PCOS into PMOS, we get to know that the name of the disease need to address all the aspect of the underlying pathology. So the PCOS is limited to organ, but PMOS is covering all the aspect of the syndrome. So this name itself demands a proper holistic care. So whenever or wherever we need the change in the perspective, we need start from the very first the name or redefining the conditions, disease condition. And medicine is always has changed after rediscovery into a new form. When we see the new discovery, new rediscovery of the any principle, or in for a better understanding right now, as we advance right now due to AI and other things, we might see that many symptoms or disease with a new perspective. The PMOS is one of them. So right now we are seeing changes in this name and treatment protocol of the PMOS. The patient with the same diagnosis require entirely different treatment strategies based on the unique biological, genetic, metabolic, and environmental characteristics. Now, as we see it from modern view, but we as a homeopath know it very well. So, how we can differentiate it or compare the precision medicine and homeopathy? The conceptual intersection between homeopathy and precision medicine. Then modern precision medicine asks the question, which treatment is best for a specific patient profile based on their genetics, phenotypes, and metabolic profile. And classical homeopathy asks the question, which remedy best matches the individual's constitution. based on physical, mental, emotional state and individual susceptibility, miasmatic aspect, and physical particular symptoms of the disease to that patient. Again, with the characteristics and peculiar rare quality. So, these both are the same. But in case of precision medicine, which we see that genomics or genetics, phenotype and metabolic profile are accessible. They can access it by biochemical markers or various uh, various margins or ranges or limits. But in the classical homeopathy, when we tell that physical characteristics, emotional state, and individual susceptibility, most of them are patient centric and subjective feeling of the patient. And again, the more the sign and the physical characteristics and the understanding of all the patient subjective feeling is dependent on homeopathy. So, the subjective feeling of the patient and understanding of homeopathy is both are individual. It differs from homeopath to a different homeopath, and we cannot make understand anyone that I am always true or I am always right, because they need proof. If we say that we have concept and we work on this concept, but they say no, they want proof, they want biochemical markers. So we are now on the verge that we can provide them biochemical markers through nanotechnology with homeopathy. In nanotechnology and homeopathic research, we are now getting that evidences from evidence medicines and uh, rigorous research. But into PCOS or PMOS, the strength of precision medicine is they had all the biochemical markers, reports, everything in their hand. And also now they understand the individual philosophy and the holistic assessment and patient-centered treatment. So they have the biochemical markers and evidences of the disease, and now they are moving towards the precision medicine, that is individual treatment. So they have all the aspect or they have all the aspect to give to the world that they are working on these conditions. But for a homeopath, the the principle is right, the treatment is right, and patient is gaining benefit from it. But we fail to produce, reproduce, or we fail to address the most this data of the evidence. But
Uh,
now this,
Doctor, we have only 3 more minutes. How many slides remaining?
okay, sir, there are 4 slides.
So,
I will conclude. Okay. So, what homeopathy challenges faces challenge is we requires larger sample size of the specific diseases and the higher methodological rigor, multi-centric randomized control trial for this condition specifically, and the reproduction of the research by this same protocol, that in every research we get the same result. So the homeopathy is effective and beneficial to the patient of PCOS, as we know, because we are individual care from starting. Master Hahnemann provide with or blessed with us such beautiful homeopathy that addresses the individual according to his phenotype, constitution, menstrual pattern, emotional state, hormonal preferences, sleep, appetite, mechanism, everything. So, according to these all conditions, the main or mostly indicated medicines are pulsatilla, calcarea carb, sepia, lachesis puja, and Netra muriatica. Again, these all medicines give upon best matching or according to symptomatology. Okay. So, as the modern science has now understood that they need holistic care, and they need to integrate all the multidisciplinary care according to endocrine, metabolic, reproductive, and everything. So, what are the pillars of treatment of the PCOS right now, and what we can do? That is, first is conventional treatment. That is, we monitor it through metabolic monitor and ovulation induction whenever we require. And lifestyle modification needs nutritional counseling, exercise, and weight management. And complementary supports homeopathic, individualized care, mental health support, and stress management, and patient education. So we need to integrate all the system or all the aspect of the PMOS care to gain long-term health care. So the medicine is often medicine itself often rediscovery in the new form after greatly advances. But homeopathy has said it way before it. So we always treat the individual, the underlying patient which have the disease and not the disease itself. So we now the modern science has understood the concept of individualization and they are moving forward with it. So I am very grateful to homeopathy that it is always been individualized care for a patient and it always treat the patient and not the disease. So I conclude my session here that caring for a whole woman behind the syndrome. The greatest challenge in PMOS is not simply managing hormone, it is to understand and treating individual behind the diagnosis. So only hormone management is not going to help for long-term effect. We need to understand the patient as a whole, their susceptibility and their health risks for the better quality of life. Thank you.
Thank you, Dr. DIVYA JALU. It's really a very good session. And even though only a few minutes remaining, we have no time for discussion. As you know, PMOS is a condition where we can manage it with pure homeopathic science. And
Yes, sir. Yes,
a lot of such cases were managed beautifully by homeopathic doctors all over the world. And
yes, yes.
as you know, we used to say that homeopathy is a science. It is the right, precise medicine. The so-called
Yes.
new scientific world has come up with the term
Ah,
technology, precise medicine. But homeopathy is 100% precise medicine from the very origin itself. Unfortunately, the so-called modern people didn't realize what is homeopathy. And if they realize this thing, they will know, they will say that the homeopathy is the purest and purest science among the sciences. So I'm thanking you. I'm inviting Dr. Boblin to say a few words and then we can conclude the session as there is
thank
not
you, sir.
always please care at least dedicate 5 to 10 minutes for discussion. Otherwise, that is the beauty of our sessions.
Okay, sir. And
Thank
next
you
time I
very
will
much.
take care.
Okay.
Is the name Dr. Tika Ahir or Dikwa Jalu? Which one?
Sir, my official name is Dr. Divya Jalu, but the email name is Dvitika Ahir. As
Oh,
we
yeah.
say, okay.
Okay. I shall refer to you as the official name. Thank you very much for a very, very detailed presentation and insight into PMOS by Dr. Divya Jalu on this 2122nd day of the daily webinar and uninterrupted webinar. They have given us a very good deep insight. And in PMOS, आपकी presentation देखा बहुत अच्छा लगा. Bahu
Thank you,
Danawat.
sir.
Thank you very much.
Thank you.
Thank you, Dr. Boblim, and those who attend the English session. And thank you once again, Dr. Divya Jalu and the Principal Hidat Mehta sir from your college, because the sir was instrumental in bringing all of you to
Yes.
these sessions. And
Yes, sir.
we congratulate
Thank
once
you.
again
Thank you.
to you and your college for giving so many sessions in this forum. And
Thank you,
Thank
sir.
you, Divya Jalu. Thank you. Very nice. Excellent
Thank-
session.
Thank you, sir.
Excellent session.
Thank you for always supporting us and providing such
Thank you.
platform.
Differential
sir.
between PMOS and PCOS. Very good.
Sir, there are any changes that I need to improve?
Yes, you will have to come up with some cases, because it's a forum
Yes.
where we have to promote homeopathy, not other things, because all of these things can be available in the YouTube, in the Google if somebody search. But if you come up with some cases, and that will be the most beautiful thing that we can deliver to the public, so that the public will know homeopathy can do such wonders here. Anyway, thank you all for joining the session.
Yeah,
And
Dr. Nanesh, I think we should have another session for question and answer and case taking. That will
Yes.
be
Okay.
very good.
Okay.
Yes,
Okay,
sir.
sir. I will take care of that.
Yes, tomorrow we will have a session from Professor Dr. Rinko Vishwas, and we'll be talking about stroke, cerebrovascular accident, and its homeopathic management. Thank you all for joining the session. Hope all of you will join tomorrow at the same time. Over to Dr. Mariama John to moderate the Malayalam session.